Good day to everyone joining us, and welcome to today's X Talks webinar. Today's talk is entitled Digital Pathology, Artificial Intelligence Models in Gastrointestinal Diseases. My name is Sonia Hunt, and it's my pleasure to be your X Talks moderator for today. At this point, I'd like to thank Aiforia, who developed the content for this presentation. Aiforia equips pathologists and scientists in preclinical and clinical labs with powerful deep learning artificial intelligence software for translating images into discoveries, decisions, and diagnosis. The cloud-based Aiforia products and services aim to escalate the efficiency and precision of medical image and analysis beyond current capabilities across a variety of fields from oncology to neuroscience and more. Now, it's my pleasure to introduce you to your moderator for today's webinar, and she is Dr. Gillian Beamer. She joined Aiforia in 2022 as Director of Research Pathology. She is a board-certified pathologist and scientist by training at the University of Pennsylvania and at the Ohio State University. Her research areas of expertise in pathology include inflammatory infectious diseases with a particular interest in tuberculosis. Now it's my pleasure to pass the mic over to Gillian. So Gillian, when you're ready, you may begin.
Okay, thank you so much. I'm happy to be here today. I have a few words to tell you about Aiforia, AI for image analysis. Could I get the next slide, please? Aiforia is a company, and our mission is to transform image-based diagnostics by escalating efficiency and precision beyond current capabilities. We hope to provide the highest quality solutions for AI-assisted image analysis to enable personalized and democratized care for patients. Could I have the next slide, please? We have a really versatile cloud-based platform for image management and AI analysis shown on this slide. I'm not going to go over all of the details for you, but I wanted to point you to some interesting use cases over on the right-hand side of our slide. And those use cases can include preclinical research, medical education, and clinical diagnostics. And today we're going to hear a little bit about a case for clinical research and clinical diagnostics. Could I have the next slide, please? Aiforia has users around the world, and this includes over 5,000 users in 50 countries, and over 1 million images have been analyzed with Aiforia, with hundreds of AI models developed. And now I think I get to introduce our speaker for this morning. Dr. Roger Moreira is an MD pathologist who received his degree from the Federal University of Rio Grande do Sul, Brazil. And currently he's a gastrointestinal pathologist at the Mayo Clinic in Rochester, Minnesota, where he's been for the last 10 years. For the last couple of years, he's been working with Aiforia to build some really interesting AI models for gastrointestinal diseases. And that's what he's going to be showing you today. Roger, I think you can take over now.
Okay, thank you, Gillian, for the introduction.
You're welcome.
And thank you for the invitation. It's a real pleasure for me to be here. Today, we'll be talking about a few AI models that our team here at the Mayo Clinic has developed over the last couple of years, couple of years, with partnership with Aiforia. So basically, we're going to be talking about 3 different models, and the idea here is to show you models that were developed by our group that kind of span the spectrum of gastrointestinal diseases. So the first model is a little more complex and a little more involved. There'll be a few more slides about that one. The other 2 are quicker. But the idea is to show you an example of one disease that is an inflammatory category. The second model is about liver cancer, hepatocellular carcinoma, which is a neoplastic disease. And the final model is about iron overload, quantitative analysis, hemochromatosis, an example of a metabolic disease. So I think we can jump right into the models. The first model is a disease called Eosinophilic esophagitis, EOE for short. So very basically, eosinophilic esophagitis is a chronic allergic type disease. It presents with symptoms of esophageal dysfunction, mainly difficulties in swallowing and pain when swallowing. And histologically, it is characterized by an inflammatory process which is rich in eosinophils, and I'll show you what those cells look like in the next slide. But basically, the disease is characterized by greater than 15 eosinophils per high power field, which we call the peak eosinophil count. And EOE is a fairly common disease. It's one of the more common diseases that we gastrointestinal pathologists see in practice. In our health system alone, we probably have a couple thousands of biopsies performed every year for this indication alone. So about the histopathology of EOE, we'll talk about inflammatory cells first. This is what a typical slide of EOE looks like. The primary cell of interest is this cell here, the cells with bright red eosinophilic granular cytoplasm, usually a bilobed, sometimes trilobed nuclei. Those are called eosinophils. Just for reference, this is what a normal esophageal biopsy should look like under light microscopy. And when the patient has EOE, not only do you have a lot of inflammation, you also have cellular injury. We're going to be talking about in the next slide. So pathologists count the eosinophils present on the slide with specific attention to the highest concentration in one single high power field. Occasionally, the eosinophils will bunch up and present as conglomerates of eosinophils. Those are called eosinophilic abscesses or microabscesses, and that's also a feature of eosinophilic esophagitis. In addition to the inflammation, we also have features of epithelial injury and proliferation. So again, for reference, this is what a normal squamous epithelium looks like. Very normal looking cells here, no inflammation. The bottom of the epithelium here is called the basal layer. That's where the more immature cells, and they usually represent just a few layers. All the rest are kind of mature looking cells. When there is injury of any sort, including EOE, you have evidence of epithelial injury. The cells look angry and look enlarged. They have prominent nucleoli. You do have some inflammatory cells here, but I'm basically showing the epithelial injury. And you also have edema or fluid accumulation causing this halo around the cells, and that's called the dilated intercellular spaces, or DIS, which is also a feature of EOE. Finally, we have subepithelial or lamina propria fibrosis. Again, for comparison, this is what a normal lamina propria should look like. So very loose and delicate connective tissue. With repeated or continuous bouts of inflammation, what happens is the lamina propria becomes fibrotic. So you can compare the texture of these two lamina proprias here, and you're going to see that this was denser with a thicker, ropier collagen than what is normal. So what pathologists have to do is we receive a slide taken from a patient with EOE or suspected EOE. And ideally, we should semi-quantitate all of these features: the eosinophilic inflammation, the basal zone hyperplasia, the DIS, lamina propria fibrosis, abscesses, whether they're there or not. This takes time. There is a pretty significant degree of inter-observer variability. So the idea for this project here is to do all of this in an automated way, so we can score all of these things, hopefully in a more accurate way than humans can do, and in a way that can be scalable. So we can do this both to expedite our work, improve our workflow, and to also provide a tool for scalability in studies, including clinical trials. So this is how I build the model. Basically, as you know, we used Aiforia technologies as our platform. They're integral part of our development of all of our models, including this one. And this is the structure of our model, essentially. So we have two types of features here, the way they're recognized by the AI models. We have features that are semantic segmentation, or they are area features, and I'll show you what they look like on the model itself later. And then for every area of interest, we counted all the cells of interest. So we located them as objects, again, a different type of recognition in the system, and I'll show you later. But in all areas of interest, including the basal layer, the mature layer, we identify all the cells of interest, including eosinophils, lymphocytes, and the nuclei of squamous cells. So in the training of our EOE model, we used 48 slides. And I think the main idea for any training, for any AI model, is to include the entire spectrum of changes or cases that you want to see. So for example, in the EOE model, we had to include everything from normal squamous esophageal mucosa through mild cases all the way to the more severe end of the spectrum. So we had to make sure all of them were included. At our service here in our institution, we had 3 scanners. So even on a very even looking at the scans from a very low magnification, you can see that they're not the same. So if you train your algorithm to recognize one set of slides by one scanner, and then you switch to another scanner, oftentimes you have problems. So you have to make sure you include all of the scanners in all of their variation, whatever you use in your institution or whatever you plan to use in your study. Histology labs, the same thing. 2 H&E slides may look similar, but they have many differences, including tissue fixation, including the type of H&E that was used. So in our service, for example, here we have our diagnostic lab and we have our research lab. They're different labs, they're different protocols. So we did have to include both types of stain. So let me show you the tissue recognition for the different features as we trained our model to do. The first and a very crucial part of it is to identify the tissue that you are interested in. So in our case, for EOE, we are interested in the squamous esophageal mucosa. Oftentimes in the biopsies, we have other types of tissue, such as columnar mucosa. After the squamous esophageal mucosa ends, there is a gastric cardia type mucosa or columnar mucosa. For this particular purpose, we are not interested in the columnar mucosa, so we designed we designed the algorithm to recognize squamous mucosa only and ignore the columnar mucosa, which is precisely what it is doing here. The inflammatory cells, so the brightly eosinophilic cells that you see here, those are eosinophils. Those are primary cells of concern. They're dotted in greens as objects. Lymphocytes dotted in blue, and the squamous nuclei dotted in red. And this is our final model with all of the 3 inflammatory cell types, or the 3 cell types. The tissue layer, we are interested in 3 basic layers: the mature part of the epithelium, the immature or the basal layer part of the epithelium, and then everything else under it, which is lamina propria. So that's the mature part, the basal part, and the lamina propria part. So 3 semantic segmentation features in our EOE model. This is an example of basal layer hyperplasia. The upper fragment here, actually this is in the same case, but the upper fragment here has no basal layer hyperplasia. The green is very narrow and normal. And this particular fragment here has some degree, probably moderate degree of basal layer hyperplasia. This is an example of DIS, dilated intercellular spaces. Again, you can see the little halo around the cells. This was a pretty tricky thing to teach the algorithm to do, but it's a very good platform and it was able to do a fantastic job in the end. This is a recognition of DIS, again, as a semantic segmentation feature. Lamina propria fibrosis was kind of a difficult problem to tackle, and I'll exemplify here why. This is an example of no fibrosis, so kind of a delicate. So the green here is recognition, tissue, semantic segmentation, recognition of collagen fibers. Okay, so this will be a normal case, so very delicate, kind of thin little strands of collagen. This is a case of mild to moderate fibrosis, and you can see denser, ropier, thicker collagen fibers, and this is one with severe fibrosis. And the solution that we found for this problem was, okay, we're going to measure all of lamina propria, and then we're going to measure the collagen. The ratio between them, so area of lamina propria over area of collagen, is going to give us a ratio, which is the lamina propria fibrosis score that we used in our model. This is the complete model, just with all the semantic segmentation features, just a pretty image for you to look at. And then there was one special problem also, which was, okay, we recognize all of the eosinophils. So this is a case with severe eosinophilia. The model did a great job at picking up the cells, but we are also interested in identifying those areas where they cluster. So one of the solutions that we found here was to do a spatial analysis, and then every time there were a certain number of eosinophils identified as objects within a certain area, that would be flagged as a eosinophilic abscess. So there was a pretty clever way that we identified to be able to recognize this particular feature. We validated our model in a couple of different ways in comparison with original annotations, with the analytical validation module in Aiforia. And we also had 5 different GI pathologists specifically annotate areas of interest, including the cell types. We had a we were pretty happy with the F1 scores that we had in the 90s for most of the features. If you compare the performance of the model, AI versus human, and the final scores are the F1 scores are down here, with the human versus human comparison, you can see that for most of the cells, it is non-inferior. For all of them, it's non-inferior, usually it's pretty similar in absolute terms as well. The other challenge that we had in this model, and that's one of the reasons why this was a particularly complex model to accomplish, was that we weren't interested in measuring only the total counts of cells. We actually had to measure the cells or count the cells, especially the eosinophils, per high power field. So what the original idea was to divide up the tissue into high power field areas, 0.24 square millimeters. And count cells in each one of them. So in this particular one, for example, this would be the highest count, which would be reported, but then we also could report a range because we would have measured every single high power field in the slide. What the model actually looked like is way better than what I had envisioned at first. So not only did we measure every single high power field equivalent that had any tissue in the entire sample, we also color coded according to grade, so how many eosinophils in that particular high power field, either corrected for the amount of actual tissue in the tile or not corrected. Since in pathology, when we do this, we don't correct, the non-corrected version actually correlated better with what we do in practice. Anyway, so We were pretty impressed with the number of high power fields, something that we don't oftentimes think about. On average, we had 187 high power fields per slide. In adults was a little more, 250 on average, and peds 140. So it's easy to see why our counts may not be accurate, because not only do we have to count accurately, but we have to identify which precise high power field to count if we don't want to miss the high power field with the highest count within the sample. And this is an example of one of those. So when you have very high counts everywhere, it's easy, but it doesn't always happen. In this case, for example, there were a couple hundred high power fields, and there was mostly between 0 and 1. That was the grade. And grade 2 matters because that's above the diagnostic threshold. In this particular example, there was one high power field or one tile that showed grade 2. This one right here. So if you didn't look at that particular level, that particular site, you would have missed it. So when we go back there and check what the machine did, we actually counted about 16 or 17 eosinophils in this particular area. So just an example of how such an algorithm can be super precise and super helpful to us. Sorry about the pretty busy slide here, but this is just to show the stats on the agreement and correlation between the various measurements by the AI model and the pathologist. This is the various features of that we're looking for, and there was essentially a non-inferiority comparing the AI model, which is the red and blue lines here, compared to the interpathologist correlation, which is the black here. So there was non-inferiority overall and within the adult population and the pediatric population. Same thing for the actual correlation between the peak eosinophil counts between the model and the pathologist. So this is original pathologist versus the central pathologist, so pathologist versus pathologist, and this is pathologist versus AI model. One very crucial finding of the study was the fact that the correlation was very good, very high, but the counts from the model are consistently higher than the counts from the pathologist. So we actually looked into this, and every time we go back to the slides, guided by the AI model as far as where to look, so the specific tile, the specific region within the slide to count, and we recounted that, we agreed with the model more often than we agreed with ourselves or with the other pathologists. So there's a good indication, at least from our data, that the model may be more accurate and yield higher counts and accurate counts compared to pathologists, which is a very important finding. And lastly, it also correlated better, slightly better, with endoscopic findings compared to our scores as pathologists. Okay, so we will switch gears here into the next AI model that we had developed. And the next model is liver cancer. So very briefly about liver cancer. So hepatocellular carcinoma, HCC for short, is the most common type of liver cancer in humans. It is the third leading cause of cancer deaths worldwide, so a fairly common cancer. Not only that, it is a fairly lethal cancer as well. In the US, the 5-year survival is about 30% for localized disease, all the way down to 5% for metastatic disease. So a fairly bad type of cancer to have. The histologic or pathologic evaluation of HCC, we typically have the gross specimen here. We cut in the sample resected by the surgeons. We identify the lesion, which would be this area here in this example, and then we process it pathologically with our stains. This is our frontline stain here called the hematoxylin and eosin H&E slide, and then we run typically several types of special stains and immunostains. For this particular model, and this is a more comprehensive model, but we're restricted to this aspect of it today, just for the sake of time. We're going to be focusing on this particular stain here, reticulin stain, which hasn't been studied in depth as far as being a prognostic marker in HCC, but is a stain that is routinely done in hepatocellular carcinomas from a diagnostic standpoint. So a little bit about reticulin stain. Reticulin is also called type 3 collagen. It's one of the several types of collagen, and it happens to be one that is very prevalent in liver and hepatocellular carcinomas. We have a couple types of stains that do the job, but essentially there is silver staining or silver impregnation of the collagen fibers, the reticulin fibers, and that shows up in the stain as black. So all of the black strands here, those are reticulin fibers, type 3 collagen. The brown stain here, the row pair thicker collagen, that is type 1 collagen. That is not what we are interested in for this study. And we also have a theoretical background to do this, which is the reticulin has been found to be involved in the progression of cancer. It is involved in cellular proliferation, adhesion, migration. All of it may contribute to invasiveness and metastatic potential in hepatocellular carcinomas. So these are three examples, just kind of showing and illustrating the range of abnormalities that you can see in reticulin stain in the setting of hepatocellular carcinoma. This first example here was a tumor in the more well-differentiated end of the spectrum, showing a pretty high level of expression of reticulin in our stain. This one was more or less in the middle with areas of thickened plates and reticulin loss. And then this area here, a more poorly differentiated hepatocellular carcinoma with extensive abnormalities and extensive loss. So our hypothesis for this study was that if we do a careful quantitative analysis of reticulin expression in hepatocellular carcinoma, this could serve as a prognostic biomarker in the setting of this tumor. So let me tell you about the development of the model itself. So for the training set, we got about 30 resected hepatocellular carcinomas, about 400 annotations in total, just to recognize the specific fibers as it's showing here in red. That's the model. We validated in about 20 resected hepatocellular carcinomas with a pretty good F1 score. And the main variable in our study, the prognostic marker in the setting, or the proposed prognostic marker in the setting, would be a comparison between the level of expression, the area represented by reticulin in the tumor. So this area here will be the tumor. In this example here, it will be 4%. In comparison with the standard, which is our non-neoplastic liver, showing a normal expression or a baseline, a reference expression of reticulin, which in our study was 16%. So this ratio here will give you the relative reticulin proportionate area, which in this example here was 25%. So again, just to show you the spectrum and the variation that we saw in the study, we studied about 101 hepatocellular carcinoma resections with up to 10 years of follow-up. So we knew how many people had developed metastasis, how many people had developed recurrences, how many people had died, how many people had survived. So again, this is the original reticulin. This is the AI model interpretation of the reticulin. And this is the result. So 90% expression compared to, again, our reference standard. 90% for this one, so a high level of expression. 50% for this one, a moderate amount of expression. And then 5% for this one, a pretty low level expression. The we were very happy with the results of this. We were able to prove that the RRPA was a very significant prognostic marker for metastasis, for disease-free survival, and overall survival. And that was true for all patients, and the patients graded as WHO grade 2, which is a special consideration in liver pathology because we don't have any further classification for those patients. So in both groups, the reticulin was very predictive of the cancer-related outcomes. Again, we have a few other things that we can use for that, including our tumor grading and the pathologic staging. And the RRPA performed fairly well, very robustly compared to the available prognostic data that we can extract from histopathology. So several other things, we have many different plans for this model here. We're currently investigating this in biopsies. We're investigating this in liver transplantation or patients undergoing liver transplantation for hepatocellular carcinomas, and we're currently recruiting outside institutions to be part of the study. So stay tuned for more results on the subject. And so we're switching gears again to our third model, which is the identification of iron in the liver. So hepatic iron accumulation, which is also called hemosiderosis, can occur in various organs, and liver tends to be the center of the focus because it's the more accessible organ and the one that tends to accumulate more iron. There are a couple of different reasons why people can have accumulation of iron in many organs, including the liver. Genetic reasons, which is called the hereditary hemochromatosis, and there are a few different mutations that can cause this. But there are also non-genetic causes, chronic liver diseases, and also patients undergoing multiple blood transfusions, whether they have leukemia or some kind of hematological process. When you get many blood transfusions, over time you can have iron accumulation in your liver and other organs. When we get a liver sample, we assess iron through special stains, and the stain that we use is called the Prussian blue stain. Just a little bit about liver histology. These here are the main liver cells called hepatocytes. Within the liver, we have the spaces here called portal tracts. Within portal tracts, we have vessels and bile ducts. So that's where many of the contents produced by the liver cells will flow in and out of the liver. This is a negative Prussian blue stain for iron, just for reference, and these are two positive stains showing two different patterns. The lower pattern here is hepatocellular accumulation of iron. So the iron is actually accumulating within the hepatocytes themselves. So these are the main liver cells, and in the cytoplasm of those cells, you have the blue pigment here, which is iron. That is abnormal, and there's quite a bit of it in this particular example. In hereditary causes, you tend to have this pattern, hepatocellular iron deposition. In secondary causes, such as blood transfusions, you tend to see the iron accumulation in a different cell type. The cell type is called Kupffer cell, and the Kupffer cells are within the sinusoids, which are the small vascular spaces within the liver. So you can see that the hepatocytes have perhaps some iron, but most of the iron is accumulating in a different compartment, which is called the Kupffer cells. So this is a secondary iron overload pattern. So when we evaluate for iron in histopathology, we get the liver biopsy. This would be a core of liver obtained through a needle. We process this tissue and embed it into a paraffin block, which is being shown here. We cut that little 4-micron slice of it, and we get an iron stain. This is Prussian blue stain. When we need to measure the iron biochemically, which is what is routinely done now, when this is needed in the histopathologic sample. It is the tissue from here is carved out of the block. Oftentimes when it's a relatively small sample, the whole thing is carved out, so it's destroyed. And that is ground up and analyzed in the machine, such as the one that we use here, which is ICP-MS, which is a mass spectrometry machine. That gives you the concentration of iron per milligram of dry tissue. And according to the patient's age, this is converted into a clinical score, which is the hepatic iron index. The diagnosis of hemochromatosis partially relies on this index here. So what we're trying to do with this model is to interrupt the process. Instead of having to destroy the tissue, instead of having to wait and spend all the resources to do iron quantitative analysis on the tissue, we tend to, what we want to is to use the iron stain, which we get routinely anyway, and analyze that through an AI model to get the digital iron concentration and an analog of the hepatic iron concentration, which is the digital hepatic iron index. So what we did was we took 59 cases, again, spanning the spectrum of things that we want to see: biopsies, resections, wedges, from 5 different laboratories, just to account for variations in the iron stain, 2 different scanners. And we trained the model to recognize not only iron pigment, but also the different compartments in the liver: portal tracts, the different structures within portal tracts, the lobules, hepatocytes, Kupffer cells, in addition to iron. We validated that in about 19 cases, and then we applied it to our test set of 98 cases. The structure of the model is shown down here. We're basically interested in lobules versus portal tracts, and within the lobules, hepatocytes versus Kupffer cells. Within the portal tracts, again, we have different structures that hopefully we could tell if the iron was in one of those. Very high F1 scores in our training set and in our validation set. We're pretty happy about that. This is an example of what the model can do: tissue recognition, lobule versus portal tract in red, lobule in dark blue, hepatocyte versus Kupffer cells in green, hepatocytes in blue. This is a secondary overload pattern here in which that would be useful. And then portal tracts with the portal stroma in yellow, and then portal structures in pink. Iron pigment, again, showing iron in Kupffer cells in a secondary overload case, and then iron within hepatocytes in a primary overload case. Primary overload case here, the entire model with all the segmentation areas and iron recognition, and then secondary iron overload pattern with iron predominantly within the Kupffer cells. We compared the iron recognition and quantitation with our routine histologic scoring system. We have 2 that we use clinically, and then we have one that is a more comprehensive one that we use in a research setting, and it had a pretty high correlation with the total iron as measured by our histologic systems, both in biopsies and resection specimens. And this is the correlation between the AI model and our gold standard, which is the ICP-MS measurement biochemically. And there was a pretty high correlation in all samples, especially in our target sample, which is the biopsy samples. And then finally, when we compare it to the clinical final score, which is the hepatic iron index, if we generate a digital hepatic iron index, regardless of what specific cutoff you use, we had very high areas under the curve, both for all samples and biopsy samples only. So with that, I would like to conclude saying that AI models of inflammatory, neoplastic, and metabolic diseases can be very useful in solving practical problems in gastrointestinal pathology. These models can be created by people without specific knowledge in AI or digital pathology or coding, such as myself. And I would like to thank the Aiforia team for all their support. I would like to thank my colleagues in the GI pathology department here at the Mayo Clinic our research fellows and residents. I could have done, we could not have done any of this without their help. So with that, I would like to take any questions that the audience may have. And Sonia, back to you.
Well, thank you very much, Roger, first of all, for that great presentation. I hope everyone enjoyed it. And now we're going to begin the Q&A portion of the webinar. And with that, I'm going to pass it over to Gillian to moderate. So Gillian, when you're ready, you may begin.
Okay, excellent. Thank you. I love the questions. I can see them. And let's see. We do have a couple of questions related both to the kind of scanning technical process and then some related to the models in particular that you talked about, Roger. I'm going to start off with one that's related to your EOE model. And the question is regarding fibrosis. It's looking at the levels of fibrosis. Can you also use special stains, or do you use your own annotations to train the model? So I guess that's actually two different questions.
Let me see if I got the question. So we didn't use any special stains for the training or for anything. So all we used was routine H&E slides.
Okay.
And so we didn't do that. Then what was the second part of the question again?
The second question was about annotations. The audience member is wondering if you used your own annotations to train the model, or maybe you could talk a little bit about the annotation process, and I can chime in from the Aiforia side as needed.
Yeah, so for the specific case of lamina propria fibrosis, I think the main question is how to annotate. So what we did was we annotated collagen. So lamina propria is one thing, like it includes everything: the vasculature, the spaces, the collagen, any inflammatory cells that you may have over there. That all of that was lamina propria. Everything underneath the epithelium that is not muscle, right? So so that's one thing. In our model, we recognized collagen. So we just annotated the collagen, just kind of small annotations, just a pink, the way collagen looks on H&E. And the model did a pretty good job at recognizing those structures. The scoring that we did was a ratio between the lamina propria area and the area occupied by collagen alone. In the end, it wasn't a great predictor, because when you have EOE and fibrosis, you also have inflammation and neovascularization of that area. So it kind of diluted the total area, and it didn't do precisely what we thought it would do. The model worked great, but the thinking behind it has to be refined, and perhaps this has to be the scoring has to be done differently.
Yeah, that makes sense. You have to learn to think like artificial intelligence instead of a really intelligent pathologist.
That's right.
Right. Let me take a look at one of the other questions. This is about scanning. So the question is, did you have to apply any kind of pre-processing to your images to make sure you could accommodate for different kinds of scanners?
Yes, so that would be a good idea, I think. So the initial part of our project was basically a proof of principle. This hadn't been done before, so we had to make sure that the grading and staging of all the features could be done, and I think we proved pretty unequivocally that it can. The second step is the application of this. So our model is working very well for our internal cases, which is we have a specific scanner here, we have a specific H&E process, so it's working well there. If you want to use that for outside cases, it is going to be different scanners, it is going to be different processing, it's going to be different tissue fixation, they're going to look different. So yes, you have to do that. So you either have to train your model using sufficient variation from outside of your institution, from perhaps dozens of labs, so that it is generalizable in that way, or it's not an either or here, it could be both, some sort of processing of the pre-processing of the slides, so that it looks more similar to what you have already trained in than what comes your way. We haven't done that yet, but we have all kinds of plans for this model. Gillian knows very well. We're working very hard on it. Yeah, image pre-processing is not part of our current plans, but we are definitely exposing the model to different stains and different studies from different stains and different scanners from many different institutions. So hopefully that's going to be a generalizable model.
Okay, I had a related question as in terms of thinking about what could be more easily clinically implemented or used clinically. Does one of those situations fit better than another, like the pre-processing of images or having models trained on the widest data set you could think of? Is one of those more practical?
I have very little experience with pre-processing, Gillian. Perhaps you can talk more about that because I haven't done that in any of my models yet.
No, I don't have a lot of experience with it either. Okay, there's an audience question that is, what is the current inter-reader variability in quantitative terms? And I'm not 100% sure what model that is referring to, but maybe if you had a general answer. I think it's asking about between pathologist variability.
Yeah. So yeah, it depends on which one model. So the iron model and the reticulin model, they're dealing with very specific things that we don't typically quantify in that way. So I can't tell you that because it's not something that is usually done. In EOE, there is data about it, and there's a fair to good correlation depending on which one feature you look at. So I mean, I have to can't remember off the top of my head, but the correlation will be in the range of 0.65 to maybe 0.9, depending on which one feature you're looking at. For eosinophils, it tends to be better than average, but from some of the features, it's not very good. For DIS, for example, it's not very good. For abscesses, it tends to be on the low side. And for some of the features that, again, we were not looking at the model, but some of the features that we look at histologically, the correlation is so low that we tend not to include in the scoring systems. Dyskeratosis would be one of them. Surface epithelial alteration would be another one. The inter-rater variability tends to be pretty high on those. But the hope for the AI models is to get something that is decent now and get it to be much better. So if you give me the same exact slides and 2 different days of the week, I guarantee you that there's going to be a 10-20% variation in my counts. That's something known. Every pathologist knows that. If you give the same slide to an AI model, the difference is going to be negligible. It's going to do the same thing as many times as you ask the model to do it. So the accuracy that these models have is something that is not attainable when we do things the way we're doing currently.
Okay, I'm squeezing in one more question because that's a great question. And a compliment to you. Your examples show good clinical relevance. What's the path forward to be able to use them with patients?
Well, it's a long one, I think. So because it's a one thing to have a proof of concept that something works, and the other thing is to have something to prove for diagnostic or prognostic purposes. The EOE model is the one that we are getting closer to that. So we have published this paper. There's the second publication coming along. So we're validating that in our internal cases. We have a second phase of the study here that is evaluating this in 5 or 6 different institutions in our consultation cases as well. So that's the next step to prove that this is accurate and does what it says it does for different patient populations. Yeah, so that is the beginning of the process of validation, and we have plans for 2024 for this to be a fully validated model and used in the Mayo system for diagnostic or at least for quantitative purposes.
Excellent. So we'll stay tuned, and that concludes the audience questions. Thank you.
Okay, well, first of all, I'd like to say thank you very much to our audience members for sending in their questions. I'm sure we all appreciate that. Roger and Gillian, thank you so much for that. So as Gillian says that we have reached the end of the Q&A portion of the webinar. If we couldn't attend to your questions, the team will follow up with you after this presentation. And if you have any further questions, here we go. Please direct them to Gillian. There's her email address. She'll be very happy to speak with you and reach out to you.
Absolutely. Absolutely.
Okay. Thank you very much, everyone, for participating in today's webinar. Okay, now please join us in thanking our speakers once again, Gillian and Roger, for that very insightful presentation, for answering all your questions. So thank you very much, Gillian and Roger.
You're
And all
welcome.
smiles. Perfect. Thank you. We hope you found this webinar informative. It has been my pleasure to be your webinar moderator. On behalf of the team here at X Talks, we thank you for joining us. I'm Sonia Hunt. Until next time, please take care and bye for now.